Thank you. So, I will take a few minutes to share the guideline. Recently, we have published in ophthalmology. Although this we will show very shortly, but maybe this guideline we have taken 2 years. So we come from Tianjin Eye Hospital. This guideline is international. So when we do this guideline, from the RK, PRK, LASIK, now we have a very special experience. We have KLEX. We know the KLEX as most as small surgery and small pro. So we found the KLEX is new technique. Although we call the KLEX, but we think in the world the surgeon only done the small surgery now recently have ATOS and other kind of surgery. But we think so many new technique we need to know. And we found for the guideline, not so many guidelines, especially for the KLEX, this kind of surgery. For AAO, only some cancers and the guideline PPT, but no KLEX, this kind of surgery. So we just make a complication for international guideline, and we found the right institute from our university and our association. And this guideline, we have done this very strictly according to the international standard, WHO handbook guideline development and the evaluation instrument agreed to and the right one and the duplicate counters. That's very strictly. So even for this guideline for the surgeon, but we also very care about the patient's the thinking. So we have, before that, we have make an investigation to make a calculation from the patients and to say what had feeling for the patient for the guideline. And also the proposal as, because at the very beginning, we in China, we just the beginning of the for small surgery procedure, so many conservation about this kind of surgery. The most surgeons think maybe the LASIK, photoLASIK as maybe the best surgeon in the world. So maybe when we try to do the small surgery, maybe at the very beginning the vision recovery is not so fast as photoLASIK, and maybe have taken a longer learning curve and so on, and astigmatism and the low myopia. And also without eye tracking, maybe for astigmatism is very difficult. And what should design for the optical zone, and so many questions we don't know. So we try to find the database from website, and from here you can thousands studied have them, but we found none of them is talking about the KLEX surgery and the small surgery. And so many studies, we set up the new study, and we are according to agreement, and we also done a lot of review. And finally, we propose nearly 14 questions and try to make a recommendation. But finally, maybe take longer time, so we just have 15 questions, including pre-operative and during and after surgery. That's a summary for the question. So from the skinny of for this indication, this kind of surgery, and also including the relative, the complication, how to make a prevention and how to control that. For example, there's a question. That's the influence of biomechanical property on the surgery. That's very complicated. So we just try to find so many studies, and also our team have done a lot of study on this. For example, for the keratoconus, we think maybe the topography and the combined biomechanical maybe as necessary to make a right diagnosis. And most of the index among that, maybe TBI and the CBI and the CRF may be most sensitive from the study. And also we found maybe biomechanical will after surgery preserve this property compared with LASIK. Although someone think maybe LASIK is a good one, but in terms of biomechanical property, maybe that's better than the LASIK. And also optical zone design also affect the biomechanical property. And also maybe the biomechanical property for the patient maybe influence surgical the accuracy. That's very important. And also we found all those PDA and RAT, we should base on the removed corneal tissue, not including the flap or cap. That's is different with the LASIK. So when we make a calculation, we just calculate the corneal tissue, the removed. And also for the safety limitation, we just thinking maybe before that, we just thinking maybe 250 as a good one. But for small surgery, maybe we think 280 millimeter, and the RAT index should be very important. That's as a good suggestion for the whole surgeon. And also we found we should have a thin cap for the biomechanical property. But that is very dangerous for have a very extremely thin corneal cap because maybe the bubble will have destroyed the epithelium. And also the large optical zone maybe have contribute less understanding and also as good for high order operation. And also the thin corner and high myopia should be taken care about. And also we have for astigmatism, we think that's quite good for X alignment and circulation control is very important. And also this up to now so many years the surgeon just thinking maybe the center of the pupil center is good, better. After this investigation, we found the CSCLL may be better than the center of the pupil. And also for the glare and the helio, so many patients is worried about. Actually, for the surgeon, our study found if a little bit this location maybe doesn't matter, but if a larger one, maybe it have a big effect. And for the angle kappa and there's should be have a control. And so also refraction measurement accuracy, so many multiple factor will have effect. And also when the possible secondary as a fraction is needed. And also for the nomogram as another topic, and actually not only by the refraction power, but also by the age and the eye and the diameter and the biomechanical property, the cap of the thickness. So that's very important. So up now we have used AI to make assessment for nomogram. Okay, so many things we must thinking about, and also before and after surgery and during the surgery, and the prevention for the suction loss and the black spot, and also the lenticule fragment, and also many things, and the fragment, and the DRK such as this. So how many control this? So there's a lot of questions concern about small and K-like surgery. So that's near the end of this guideline. So you know this can take 2 years and maybe even thousands of pages, and maybe the time is so limited. If someone more interesting, you can find this paper of ophthalmology. And finally, thank you all the support, and thank you all the contributor for this guideline. and from the world and our country. Thank you. Thank you very much.
Thank you so much, Dr. Yan. 2 years of work, thousands of people review. You did very well in 8 minutes. Thank you so much for that. I would like to invite the next speaker, Dr. Takashi Kojima, to actually do the presentation. I think that's a very, very important publication that we have, and that's a benchmark, and that's being used by our center to actually develop the training method and go step by step by looking at the evidence given by that. Dr. Takashi?
Thank you so much. First of all, I'd like to thank all the staff members of ZEISS Meditech for inviting me such a great meeting. So let me start my presentation. So I'm working in the Nagoya Eye Clinic, and I'm proud that many physicians underwent refractive surgery at our clinic. As you know, most of the Japanese physicians are very cautious and conservative, so I'm really proud of this evidence. So this is a SMILE journey at our clinic. We actually introduced the Visumax 500 laser, the first installation in Asia, 2008. And we started SMILE procedures 2012. And we recently achieved 3,000 SMILE surgeries. It's not so big number, but we kept continuing these surgeries. And we, a couple of days ago, we just introduced Japan's first Visumax 800, and we'll start next week. Next week's SMILE Pro. At first, I'd like to talk about the refractive surgery market in Japan, and also the story about LASIK and ICL. So this is a market size of refractive surgery in the world. So the market size in Japan is really small, but when we look at the proportion of the surgery, so you may notice the big difference from other countries. In Japan, the majority of refractive surgery is phakic IOL, almost 70%, and SMILE is very small percentage, and LASIK is about 30%. Now, in our clinic, also the similar trend. We do the ICL almost 70%, and we have that SMILE 27.7%. Let me talk about the tragedy of LASIK in Japan. So we had many cases of LASIK in 2008, almost 450,000 cases LASIK. But just after 6 years, they dropped to 50,000 cases. During this period, there are several things happened. First, global financial crisis, and then outbreak of cluster infections related to LASIK at single clinic. And finally, the government agency issued a public warning regarding LASIK. In Japan, actually, the doctor's license, like MD license, is very powerful, and we can do anything. So, we can start non-approved surgery and also import machine. And so at that period, the quality of the surgeon is very low, and they did low quality of surgery, and there were so many unfortunate LASIK patients. And finally, people lost trust for LASIK. Still, this is still some patient has this image for the LASIK. But ICL succeeded in Japanese market. So the reason is that the ICL study group worked to avoid the same mistake as LASIK. I'm also the core member of the ICL study group, and they did effort to promote the appropriate use of ICL. They did establishment of a certification system in collaboration with Star Japan. So we checked the surgery. We went to the operation room and checked the surgery, and if the quality is not good, the doctor cannot get certification. So this is very strict. So we also did educational activities by the educational activities, and also seminars and information dissemination through the official website. So this slide shows my expectations for Khairidzan Meditech in promoting SMILE in Japan. So with the approval of SMILE in 2023 and SMILE Pro in 2024, it's now expected that Khairidzan will actively contribute to the promotion of both SMILE and SMILE Pro in the Japanese market. So moreover, we expect that Khairidzan will not merely focus on selling laser mesh systems, but will also take responsibility in evaluating and maintaining the technical standards of surgeons and clinics, ensuring high quality outcomes and patient safety. We also developed Relax SMILE research group in Japan. I'm the member of the group. We expect that Khairidzan Meditech works in close collaboration with the Relax SMILE research group to support both academic activities and enhancement of patient awareness regarding SMILE and SMILE Pro. From here, I'd like to introduce my research work about SMILE procedures. So I think the biggest advantage of SMILE is less dry eye compared to the LASIK. So this is we published in Japanese journal. So this is contralateral eye study, one eye SMILE and the other eye for LASIK. And we found that cornea sensitivity is more, cornea sensitivity is maintained in the SMILE group compared to the LASIK group. We also found that spherical aberration in the SMILE group after surgery was less than the LASIK group. We also reported 10-year outcome of SMILE. The number was not so many, but we found the first efficacy after 10 years after SMILE, 88% of patients achieved UCVA over 20/20, and efficacy index was 0.79. About safety, 47% of patients showed no changes. Average safety index was 0.96. Stability, average spherical equivalent, 10 years after SMILE was minus 0.29. About accuracy, 84.6% eyes were corrected within plus minus 0.5 diopter. Astigmatism correction is also very high. 90% of eyes were accurately corrected within plus minus 0.5 diopter of manifest refraction. So summary of SMILE outcomes: less dry eye than LASIK, less induced spherical aberration, which will result in higher visual quality than LASIK, and long-term safety and efficacy is high.
Thank you. That was a wonderful topic.
Okay.
So we look forward to hear your success stories of Visumax 800 in future forums. With that,
Thank you.
I welcome Dr. Taekeun, who has done a lot of work with the artificial intelligence to talk about beyond conventional SMILE.
Hi, I'm Dr. Taekeun from Hangul Eye Hospital. Okay. This talk is divided into two parts. First, I will talk about continuous curvilinear lenticulorhexis. CCL, we already seen that, and the next issue is AI. Okay. Let's begin with lenticulorhexis. The concept is simple. Instead of performing full anterior and posterior dissection, and then removing the lenticule, and lenticulorhexis allows surgeon to create a controlled circular tears similar to capsulorhexis in cataract surgery. Okay. This table compares the main techniques for lenticular extraction in SMILE. The CCA, the conventional dissection and dissection method involve full dissection of both plane and extraction using two instruments. It's reliable but can be time-consuming and requires precise plane identification. The push-pull maneuver helps break adhesion, but it's complex. Few studies have compared the Lenticulorhexis with traditional dissection technique. In one study published JRS, at 1 month post-operative, all patients in both groups achieved visual acuity of 1.0 or better. Okay, safety and efficacy indices were similar. Importantly, lenticule was better preserved in the Lenticulorhexis group. Okay, surface smoothness is major differentiator. Studies show that lenticules extracted with Lenticulorhexis demonstrate smooth, regular surface, whereas traditional method results in more surface roughness and micro tears. Okay, let's summarize the two approaches. Conventional dissection requires dissection of both plane, careful separation, and multiple passes. It's effective, but technique dependent or time consuming. Lenticulorhexis CCL combines dissection and extraction into a single step, so it's very intuitive, so it's ideal in fast, high volume clinic. Okay, Visumax 800 has been a key enabler of Lenticulorhexis. Its high-speed scanning produces precise side cut, reducing OBL and improving edge definition. This allows the surgeon to grasp and remove the lenticule without excessive manipulation. Okay. Now, this video shows continuous curvilinear Lenticulorhexis performed without any dissection. The lenticule is removed in one smooth continuous motion. If it is tough case, but following the edge in the circular path, very similar to Capsulorhexis. Okay, we have no time, so we'll move on quickly. It's tough case. Okay, at Hangul Eye Hospital, we conducted a paired eye study with 21 patients. One eye received no dissection Lenticulorhexis, and the fellow eye underwent conventional dissection. We evaluate the outcome using OQAS for visual quality and visual acuity, and Kasetsuwan imaging to assess the interface intensity. Okay, post-op Kasetsuwan scan shows clear interfaces in both techniques, but we noted slightly lower reflectivity and fewer micro distortions in Lenticulorhexis group. However, no statistically significant difference were observed in many values. Okay, so, but while the difference were not significant, the values consistently trended slightly better in Lenticulorhexis group. For example, OSI was 2.18 versus 2.33 in one day post-op. So in short, Lenticulorhexis is at least equivalent to conventional dissection outcome, okay, with a potential for smoother recovery and faster workflow. Okay, success of Lenticulorhexis requires three things. First, a clean laser edge, maybe a fast system like the Visumax 800. Second, a healthy, clear ocular surface to avoid black spot. So no MGD or corneal erosion is important. Third, avoidance of OBL during the procedure, as this can obscure the lenticular edge and hinder extraction. Okay. To conclude this section, Lenticulorhexis offer comparable outcome to conventional dissection, and let's shift to the next session, AI. As SMILE become more widespread, we need tools to personalize personalized planning, predict safety, and automate follow-up. So the key idea is here, using AI to personalize treatment, improve safety, and reduce variability. First, AI enables better screening. Machine learning model or like ChatGPT models can detect keratoconus or predict ectasia risk from topographic or biomechanic data. Okay. Our team has developed multimodal AI models to integrate these data sets. This slide shows how AI can accurately calculate the key safety indicator like RST or PTA or landmark score. Next, AI supports personalized planning. We recently submitted a manuscript showing how ChatGPT can create surgeon-specific nomogram using real-world data. It performed regression modeling with comparable accuracy to statistical softwares. This slide shows just how easy to develop a customized nomogram using ChatGPT. We simply gave it post-operative data like sphere, cylinder, K value, pupil size, and ChatGPT performed linear regression automatically and generated formula, even built HTML code for a working calculator. In our study, ChatGPT generated nomogram predicted post-operative refraction with greater accuracy than empirical formulas. The AI model reduced the error and eliminated the needs for manual coding or statistical packages. These studies highlight how AI can help us predict post-operative outcome in SMILE. The first model uses surgical video to detect pattern like OBL or black spot, which correlate with early vision recovery. The second study, our own study, combines preoperative data and fundus image to predict long-term myopic regression using machine learning models. Finally, AI can assist after surgery. In UK, DORA, or AI Assistant Core model, for cataract surgery, which reduced the clinician burden while maintaining patient satisfaction. Similarly, voice core AI can follow up with SMILE patients and assess vision and discomfort and notify clinics if needed. In conclusion, AI will increasingly support SMILE through multimodal integration, predictive analytics, and automated assistance. Whether it's planning surgery or managing cost of care, AI is evolving from a tool to a partner in refractive outcome, refractive surgery. So thanks for your attention.
Thank you so much, Dr. Yu. Thank you for taking the time.
Thank you. Dear children, my dear colleagues, then it's my great pleasure to be here to present my experience in elevating SMILE surgical techniques for optical outcome. I'm Dr. Xingtao Zhou from ENT Hospital. And SMILE has proven to be a reliable refractive surgery method. SMILE has been over 7 million in mainland China and 10 million globally. And as in last year, in Barcelona, we did observe the ceremony. And last December, I did a clinical study with Visumax 800 in ENT in Shanghai. It's very wonderful, and all the cases has very good outcome. We followed up by 6 months, and the optical quality is very satisfactory. And in Asian Pacific International Refractive Surgery and Smile Training Center, my hospital hold specific courses for surgical technique for over 10 years. Here, may I share with my technique of smile, and I will guide you those technique aspects. They can enhance the skills, particularly the early learning cue with the beginners in performing the surgery. And first of all, it's the difference between the beginners and experts. Smile surgery is technical activity. Normally, beginners have no foundationally understanding in refractive surgery. Breakthrough field and psychological fields such as a field is crucial. And experts may have more professional surgical technique with accumulated rich surgical experience. They could overcome difficulties during the operation. So how the beginners can quickly master surgical technique, take the right and operation approach. First of all, we have confidence with reduce the aggressive attitude and combined with systemic training and always practice the self-improving practice operation and continuous learning from the expert and the fellow. With the cooperation with the experts, so the learning curve will decrease. First of all, let's talk about the docking. Let's focus on how the docking process. One of the most important things is the centering of the white light ring, ensuring that the white light ring is centered accurately will guide the rest of the procedure. We call this CSCLR. We have to keep talking to keep ensuring the patient keep fixation to the green beam light to be very good CSCLR. And during the docking process, we have to use the centralized white light ring and centralized lacrimal ring, and about 80% watermark reaches your king section. Of course, with Visumax 800, the process much easier, even with no experience of a small procedure. And most treatment procedure of Visumax recommend using the corneal vertex as a treatment center, as we listened to the lectures of Dan in this afternoon's lectures. And initially, it's advisable to select patients with a kappa angle less than 0.2, and to avoid the too larger kappa angle. It will be very distort the fixation. The optical quality will be affected. And when we docking process, supported approaches was combined with topography such as Taekeun and CSCLR, and with calculate head position ahead and keep the fixation. Always keep talking. We let the patient's lacrimal ring based centering technical could be finished. With this is with the microns views and the laser microns view, may with the coaxial light corneal refraction method could be better to understand. Again, with Visumax 800, even we can rotate the joystick to fit the cylinder axis even much better. When the laser process, and we still should pay attention with the laser scanning with the side cut and the incision to avoid the such surprise or challenging problems such as OB or black spot or other complications. So the dissection as for the dissection technique, so initial dissection anterior plane, dissect the anterior plane first and dissect the post-plane sequentially. And sometimes we can use the CCL technique. This is for the 800 and this is for maybe just skippable as time is limited. There's a standard 5-step technique, classical and not variable. But for beginners friendly, opens incision definitions of the planes and dissection of the upper plane and the lower plane, and then extract the lenticular. Sometimes we could simplify the steps to 3 steps. The key points is dissection the upper plane and dissection the lower plane, and then extract the lenticular. If the laser scanning is perfect, you can use the CCL, which I even combined with CCL to absolutely not recommended to beginner surgeon. But I think this is my technique with, I think it's just very earlier, it was 11 years ago, I reported in GRS and with a little bit dissection with upper plane and low plane with 1 to 2 o'clock, and then to just like tearing circumferentially and to take out. Sometimes we even without to separate dissect only for low plane, just like this way, and you can find the spatula is under the lenticular, and only the one time, and then to separate upper plane, and then tear circumferentially, and so we call it the circular line lenticular cases. And with if the very perfect, so you can even without do anything and to tearing. I think it will be last for 30 seconds. So finally, the one-step CCL. Look at this video. I think less than 20, 30 seconds maybe. So now I approximately, I often with 2-step CCL for Visumax 500, but with for seldom use with Visumax 800 because I'm used to use 800. We already performed, my team already performed more than 260,000 small procedures, mostly with very good optical quality, the satisfactory ratio almost 100%. To summarize my tips to this beginners, patient guidance is very important when docking the lasering, lacunar marine centration techniques, and corneal surface protection to avoid a surprise. The most suitable recommended technique is a 5-step technique. Sometimes, if you're lucky, you can use CCL. And the load is long, to protect the visual quality. And today I just running in Seoul city, and 6 months ago I marathon in Shanghai. So we are looking forward to see all of you in Shanghai. Thank you.
So very good evening, and I'll be talking on ease of use across ZEISS refractive systems. So thank you ZEISS, thank you Wendy, Dan for having me here. And I'm Dr. Sonu Goel. I'm from Jaipur, India, and we use this 800 and MEL 90 and do a lot of Smile Pro and Presbyond. So I don't have any financial disclosures except for the travel grants for this meeting. And so this is, can I have the audio input please? Audio here? So this basically describes the workflow that we have at our center in India. Welcome to India, Anandai Hospital. I am Dr. Sonu Goel. We are one of the biggest refractive centers in this part of India. We do smiles, Presbyond, LASIK, surface ablations, and a lot of trifocal lenses. Thanks to ZEISS for giving us this wonderful workflow where we can manage our cataract and refractive patients in minimal time and with maximum quality, ensuring the best of the vision to all our patients, India and abroad. So this is how routinely the patient who walks to us, the EMR on the reception, where all the data is fed in. A routine AR NCT refractive slit lamp examination, topography, wavefront analysis, fundus pictures, Claris 700, and then IL Master 700, which actually takes those iris images, and we basically work through two different centers, and this is then flown and reaches the refractive workstation to our OR center, and these iris images are captured. And this is what gives you the data, which can be pre-fed by most of the optoms. Hi, good morning.
So I wanted to ask you about getting my glasses cleaned, so what would you suggest?
Oh, Isha. So we've gone through all your reports here, and I think you're a perfect candidate for smiles. So we do under an equipment which is called Visumax 800, and the procedure is called Smile Pro. So essentially, in 8 seconds, a lenticule is created. So how do we go about it? So we'll make you lie down on the laser bed. We'll put some numbing drops in the eye. We'll put a sheet, we'll put a tape and a clip, and I'll ask you to look at the green light. So 8 seconds is the time when you don't have to move your eyes. So you have to keep your eyes steady, you don't have to roll, don't squeeze, and just look straight, right? So within 8 seconds, that laser goes inside the eye, you don't move. So we'll count. So 1 to 10. And within the 8 seconds, the laser is done. And then we just remove the lenticule and you go to take the other eye.
That's it. Thank you. Wow, oh my god, I can actually see everything.
So I think with the improved workflow, and this is how the heart of the entire workflow is the forum and the refractive workplace, which captures the data from all the diagnostics. And this then feeds into the surgical center for the Visumax 800 and the MEL 90, where we have the Presbyond, and we are doing the Smile Pro on the Smile Pro system, Visumax 800. So this is how digitally they are all linked and talking to each other. So actually, shifting from 500 to 800 actually made us move from doing a surgical procedure from 26 seconds to 8 seconds. So indirectly, that gave us 2
quick green points. So 1242 eyes that we did, hardly 2 patients of suction loss, which is close to 0.161, against the multi-center study, which shows 1.34% of the suction loss, and majority of these suction losses were within the first half of this the suction. The first 14 seconds. So gone are those days where we actually used to look at those charts for figuring out which place. We are now playing with the energy, spot size, and the spot spacing that we actually saw in the first part of the meeting. And with the newer software that we have, shifting from 4.5 to 3 microns and the side cut to 1.5 has made our life very easy, where the tissue dissection is almost very easy. And most of the studies worldwide would actually say that the learning curve of SMILE is actually challenging. It is the lenticule dissection and the extraction which is the most difficult step, and where you actually have the entire gamut of complications occurring, like cap tear, side cut tear. But with this revised the energy settings, in our study of 1242 eyes, 72% of the patients had just mild dissection which was needed, and 24% of the patients required a mild to moderate, and few of the patients had those free-floating lenticules. And this actually transformed for the entire vision recovery for 3 months. The mean residual spherical equivalent was within 0.5 diopters in 96% of the patients. And if you see, the results have been consistent from day 1, day 7, 1 month, and 3 months. So that speaks of the ease of dissection, no tissue trauma, and the vision recovery day 1 close to almost 2020. We all know that the center align is a great tool, and any decentration more than 0.3 is bound to increase the aberrations and the coma, and that actually translates more if you have a higher magnitude of cylinder. So centration with this, the lollipop as Dan calls it, has been a great tool, and we always, if you see here, this is has to be less than 0.1 millimeter. So you actually see how much is the drift from the center, and this actually describes whether it's 100 micron off your axis or 200 microns, and this turns out to be blue if it's bang on the center. And what this translated into a practice of 1242 eyes actually correlates with this wonderful paper which speaks of the effect of intraoperative angle kappa adjustment on higher order aberrations after small lenticule. And it showed actually the adjustment of angle kappa during SMILE resulted in less HOAs. And this actually correlates with our own study of 1242 eyes. The HOA fell from 0.31 to 0.16 day 1, day 7, 1 month, and 3 months. Similarly, the coma went down from 0.17 to almost 0.1. So that talks of the quality of vision, the contrast, which we have been able to achieve under this wonderful system. So another great feature of this is the cyclotorsion that we have been using. Initially, what we were doing is that we were marking on the slit lamp the 0-180, and then we were trying to adjust. A lot of fallacies in this, but with the getting in of this wonderful cyclotorsion alignment, if you see here, on the go, there has been a cyclotorsion of 5 degrees. Then you can manually rotate the joystick and actually make it 0 correspondingly. So tackling cylindrical axis has been great, and this actually showed that we just did recently acquired this, had 52 eyes that we did, and no rotation was required in just 13% of the patients, but rest of the patients required close to 0 to 3 in 46 degrees. But what is interesting is 4% of the patients actually required a rotation of 10 to 12. So this actually translates almost a 30% loss of the astigmatic correction. So that means if you have a cylinder which is close to almost 3 or 3.5, you're leaving a residual still of 1.5. So in our own study with the Oculine, the cylinder correction from 1.24 went down as close to 0.01 on 3 months post-operatively. And this depicts with and without Oculine. So without Oculine, 1.094 was the average cylinder, went down to almost 0.39. But with the acquisition of this on 52 eyes that we did, a 1.24 average cylinder went close to 0.01 diopters. So the safety index 1.01, efficacy close to 0.94, So take home actually is what actually the workflow helps to in terms of both the patient and the surgeon. Patients are happy with great surgical results. They are satisfied. Less suction duration means less pain. Patients are comfortable. They spend less time in the OPD and the OR, so less man hours, and they have peaceful nights. Same holds true for the surgeon. The transcription errors are less. It's a more workflow. Initially, we were doing on an average of 4 smiles per hour, but now I'm able to take 6 to 7 cases in an hour, so less surgical and OPD man hours. We are able to correct more precisely the cylindrical errors, the cyclotorsion compensation, the HOAs. Less suction loss means less of the release of inflammatory factors in the eye, so early healing, so patients are more comfortable, and so is the surgeon. Thank you very much.
Good evening, everyone. I would like to thank ZEISS for having me in this wonderful symposium. So I think we're already running short of time, so I'll be quick. So Visumax 800 is the new kid on the block and everyone is talking about it. And I'm here today to share my experience with the Visumax 800 in treating astigmatism using the Oculine software. Okay, so these are my financial disclosures. So a few years ago, when we used to search astigmatism correction with smile, we would get some of these papers which would show that the results of astigmatism with smile were not as great as LASIK, and there was a significant undercorrection of astigmatism observed with smile. And of course, these results were published with Visumax 500, wherein there was no automated cyclotorsion available. And many researchers tried to compensate this manually, and these are some papers that have been published. However, the manual compensation of cyclotorsion required corneal markings, and these markings had to be done using an ink or some metallic markers, which of course sometimes made the patients uncomfortable, and it also increased the surgical time. So now we have the Visumax 800 with its super fast 2 megahertz frequency and some of the great surgeon assistance functions such as the Centraline for centration and Oculine for astigmatism correction. So the Oculine, as we all know, is basically a software that corrects for cyclotorsional movements, and thanks to the digital connectivity between the ZEISS instruments, the IOL Master 700, the Refractive Workplace and the Visumax 800 that enable this. So this is just a short video to show how it works. So basically you have the image from the iris image from the IOL Master on table. And so basically you can see that the surgeon, the software calculates the cyclotorsion. So in this patient it is 4 degrees, so it is matched with the live image. The surgeon can toggle between the two images to verify the iris landmarks if required, and once it is confirmed, then you can go ahead with the lenticule creation. So in my experience, so in my new center I have treated so far 75 eyes with Smile Pro, of which 47 eyes had astigmatism, and all these eyes were the astigmatism was corrected using the Oculine assistance function. So we divided the total eyes into 2 groups, low cylinder group and high cylinder group. So the low cylinder group had 25 eyes wherein the cylinder was within 1 diopter, and high cylinder group had 22 eyes with cylinder more than 1 diopter. So this is the pre-op comparison between the 2 groups, and the age, sphere and spherical equivalent and vision was matched. But cylinder, of course, there was a significant difference. The mean cylinder in the low cyl group was minus 0.5 diopters, and in the high cyl it was minus 1.86, and the highest cylinder treated in this series was minus 3.5 diopters. Intraoperatively, optical zone, lenticule thickness, minimum, maximum were matched. If you look at the cyclotorsion in degrees, for the low cylinder group, on an average, it was 3.4 degrees with a range between 1 to 11 degrees. And in the high cyl, the average cyclotorsion was 4.2 degrees, ranging from 1 to 12 degrees. And this is one of the cases in the high cyl group where you can see that there was a 10 degrees of cyclotorsion, which was well compensated by the software. So at 2 weeks, this is the comparison of results. So sphere was comparable. Cylinder was also comparable, and you can see that in both the groups it is very minimum, minus 0.06 in the low seal group and minus 0.09 in the high seal group. The SC, UDV and CDV were also matched. So regarding the efficacy, as you can see, all eyes in both the groups had 20/20 or better vision. There was no loss of lines of CDBA, so safety was excellent. But in fact, 24% eyes in the low seal group and 32% eyes in the high seal group did gain 1 line of CDBA. When you look at the attempted versus achieved SC diffraction graph, this shows excellent distribution of the dots and very good fit with the R square of 99.99 in the low seal group and 0.98 in the high seal group. So this SC diffraction as well as the cylindrical correction in the 2 weeks post-op period was within 0.5 diopters for all the eyes in both the groups. So this is a superb result. We also did vector analysis of astigmatism using the Alpine's method, and you can see that the difference vector, the CI, which is the correction index, and the angle of error was not significantly different in both the groups post-op. And these are the graphs, vector graphs, of which the most important is the correction index. So CI or correction index is ideal is 1, and you can see for the low seal group it was 1.01, very close to 1, and the high seal group it was 0.99, again almost 1. So this is very good. And this is the angle of error, 92% eyes within 15 degrees and 100% of eyes within 15 degrees in low and high seal group. However, there were 2 eyes in the low seal group and 1 eye in the high seal group that had acquisition errors. I'm not very sure if surgeons who are using Visumax 800 have ever encountered this. So sometimes, probably because of acquisition error with the IOL master, the iris image does not match successfully on table with the live image. So in this situation, if you feel that the cyclotorsion is on the higher side, you can undock and do a manual marking. Or if the cyclotorsion is less, 1 or 2 degrees, then you can probably just go ahead. And there were no intraoperative complications observed. So to conclude, the Oculine assisted automated cyclotorsion in Visumax 800 resulted in excellent correction of astigmatism, and in my experience, I found it equally effective in low as well as high cylinders. And it's a beautiful markerless system, automated, fully automated, hassle-free, and very convenient for patient and surgeon. It also saves your time that you basically use to mark the eye, and sometimes the patients are also uncomfortable due to marking. So it avoids all those things. So, and it also improves the surgeon and patient satisfaction thereby. Thank you so much for your kind attention.
Thank you, superb. About 7 minutes sharp. Okay, I would like to invite the next speaker, Dr. Ngamjit Kasetsuwan, to actually take the floor. Yes, Dr. Ngamjit, please share with us all your experience and how to manage the complications of smile. Thank you.
Yes. Good evening, everyone. First of all, I would like to thank Khairidzan for inviting me to this meeting. What I'm going to share is about smile complication, which is a retained lenticle fragment. I will cover all of these contents in 10 minutes. I try to. What is the incidence of retained lenticle after smile procedure? Actually, there is no specific rate reported. However, the estimated incidence is less than 0.5% in experienced hands. However, during learning curve, the incidence increased up to 1 to 2%. These are risk factors of retained lenticle fragments. A thin lenticle, usually less than 50 microns. The problems of laser separation or setting, such as the OBL or back spot. Inadequate surgical experience, especially for the beginners, and in case of difficult dissection, as well as excessive patient movement. It can cause auricular astigmatism, reduced visual acuity as shown here. About auricular astigmatism, you can see in the axial or sagittal map that the red area corresponds to the retained lenticle. reduce visual acuity, refractive surprise under correction, and increase higher order aberration, especially for the coma. You can notice the coma increased more than 0.5% up to almost 2 RMS. And how to detect retained lenticle fragments? I will divide into intraoperative and postoperative period. For intraoperative period, we have to check the completeness of the lenticle every time after we remove it, as shown here. This is my fellow case. She tried to remove the lenticle, but you can see that she used excessive force to remove the lenticle. I asked her many times, I told her many times, stop, but she still continued doing that. However, finally she was able to remove the lenticle in one piece. But I asked her to recheck the lenticle. And you can notice that the lenticle was torn, so she has to examine the lenticle fragment like a jigsaw to make sure there is no lenticle fragment left in the pocket. Slit lamp mount in the laser system is another useful tool for inspecting the lenticle fragment, as shown in this video. In this case, we suspect that there is fragment lenticle inside the pocket, so we use the slit lamp examination that mount with the laser. You can notice the irregular corneal contour as well as the abnormal light reflex on the iris plane, as shown in the yellow and red arrow respectively. So at that time, we make sure that there is something wrong, so we have to remove the lenticle. Intraoperative OCT is another useful tool for detecting retained lenticle fragment. However, its use is limited since most refractive surgery centers may not have it. How about postoperative period? Slit lamp examination is a fundamental tool to detect retained lenticle fragment. It may appear as opaque lesion as shown in the slide. And if you dilate the pupil and use lateral illumination technique, you can see the lenticle, especially the border of the lenticle, more clearly as shown here. Anterior segment OCT is another useful tool to detect lenticle. It may appear as a hyperrefractive area in the anterior stroma. It may provide information about the location, borders, and size of the retained lenticle fragment. Moreover, epithelial thickness map may show increased epithelial thickness in this slide in the red area. Corneal topography and tomography is very useful for detect retained lenticle fragment. It shows area of stiffening and erosion in axial and erosion front respectively in this picture. So how to manage them? These are the ways, the methods to manage retained lenticle. We can, if the lenticle is small and located in the peripheral zone, we may observe the lenticle. However, we have to follow and monitor any changes, especially a decrease in visual acuity or the effect on quality of vision. But if we have to do the surgery, we may reopen at the same incision, which we usually do 2 to 3 millimeters, and inject balanced solution around the remnant, which cause swelling of the lenticle. Then we can see the border more clearly. Another way is to use the diluted triamcinolone acetonide or TA and inject into the pocket again, and we can see the border of the lenticle again more clearly, as shown here. Using circle software is another tool to to dissect the posterior lenticule and use branch dissector to separate anterior and posterior lenticule respectively. And this is how to do the approach the main incision. This is area number 1, and this is area number 2. So you can use this one for the beginner. Tip number 2 is how to dissect the lenticule. Look at the blue color. It represents the edge of the lenticule, and the red arrows represent the edge of the cap. I suggest to dissect the lenticule and the cap slightly beyond peripheral edge of the lenticule and the cap. And you can see that in this case, this is my fellow, first year fellow. This is her first case, and you look at this area. She dissect the cap and the lenticule, stop at the edge of the lenticule. So what happened? If this happened, go to tips number 3, grasp where to grasp and where to tear the lenticule. This is her case. After she dissect, and then she didn't know where to grasp. So where to grasp? She tried 1 and 2, the middle or the farthest one, and this is her first attempt. She tried many times. However, all of her attempts failed. So I advised her to grasp at the nearest attachment point and tear the lenticule, such as the Capsulexis line pattern or Lenticulorhexis pattern. For the tip number 4, do not use excessive force to pull the lenticule. This is another case of my fellow. Look at the direction of the pulling. She used forceful pulling. And remember this case, she can remove it, but the lenticule was torn. The last tip is to check the lenticule after the surgery, as shown here. After you remove the lenticule, you have to unfold the lenticule and check, especially the edge of the lenticule, to make sure there is no lenticule left in the pocket. Something like this. I think my presentation today will help you a better understanding of retained lenticule fragment and how to manage and prevention. And we'd like to thank Dr. Pratamon, who is my first year fellow, who helped me with this presentation, and thank you for your kind attention.
Thank you, Professor. That was a wonderful talk. If I ask one question to you, I understand you suggest circle software as one of the management methods.
Yes.
Which pattern would you recommend, if at all we have to use a circle software?
Well, circle software, sometimes we no experience of using. We have to ask the technician to use, so it's better to know another way.
Thank you.
Okay, good evening, everyone. My name is Yishu Ho. I'm from Taiwan and Chengqing Eye Center in Taipei. It's my great honor to share our experience in integrating the Presbyond and monovision, especially in the setting of the pseudophakia. This is my financial interest to disclose. And today I'm about to bring up a case with a bilateral cataract surgery, and we choose the LBV for the enhancement procedure. We will discuss about the mechanism and the treatment plan we develop, and also we hope it can give you guys a more better perspective about how to approach this kind of a case in your practice. This 69 years old female come to our clinic with severe blurred vision and with myopic progression. Patient is struggling seeing far and near. Patient already have an uneven for cataract surgery in the right eye with a monofocal lens, while in the left the cataract remain untreated. Patient has a strong demand for near-world vision, and also specifically she asked for myopic target in both of her eye. So to accommodate her spectacle-free and near-world vision demand, we choose the monofocal lens target -2 myopia for the left eye, and we select the aspheric design intraocular lens for her to assure she has the adequate asphericity and also preserve the adequate image quality. 1 week after surgery, patient have already enhanced in the near vision with the intraocular lens, and her refraction is -2 myopia. And patient is satisfied with the near vision. However, she's complained of the blurry vision in the intermediate vision. And she also complained about wearing glasses while driving. So to addressing her all this concern, we have to do is preserve the near work vision and also extend the range of focus. However, the standard LASIK is not enough for intermediate distant activities such as typing and painting. So we need something more comprehensive. LPV provides us a way to correct ametropia and also extend the depth of focus. After discussion, a patient preferred to start with the one eye first, which is dominant eye. So we plan to use a stepwise to correct her dominant eye first. However, the key question is that whether or not she can tolerate the cross blur from the anisometropia. At this stage, we are not sure. So we use phoropter to check the manifest refraction and also tolerance test. For the standard protocol of the tolerance test, we have to treat both of the eye, dominant eye to the plano and non-dominant eye to the -1.5. However, in this case, the left eye is set at the -2 diopter. So we have to try various myopia target to find the sweet spot. During the simulation, there is minimal cross blur in the last two sets. And we can see if the myopia set over the -0.75, there's distant blur. However, when the myopia is set around -0.5 diopter, patient seems acceptable with the intermediate vision and the near vision. So with the trial frame, patient reported that she is very comfortable with the dominant eye setting. Before the surgery, we also checked the total eye surgical operation, which is about -0.4 micron, which is equivalent to the 1.3 diopter depth of focus. So except for the tolerance test, she also passed the fusion test. And although the intermediate visual acuity is only ZEISS, however, we think the blend zone created by the LBV will compensate for the intermediate vision. So we choose the LBV for the enhancement. Just 1 week after the LBV, patient adapt to the new refraction very quick. Patient is satisfied with current condition and 20/20 in the distant visual acuity, and the intervisual acuity is J3, and the near vision acuity is J1. And patient reported no blur vision in the intermediate distance activities such as typing and painting. And to her surprise, she doesn't need to wearing any glasses while driving. So what's the underlying mechanism for this? LBV used the non-linear aspheric ablation profile along with the Mohd's monovision and induced the Mohd's adequate spherical aberration to increase the depth of focus. In both of eye, the total spherical aberration is around -0.4, which is equivalent to 1.3 diopter depth of focus. So thanks to the EDOF effect, even with mild myopia in the dominant eye, patients' distant vision is still not compromised. And also, patients tolerate very well to the close blur from the anisometropia. So the significance of this case can extend beyond to the others. So the LBV opened the opportunity in the pseudophakia case with monofocal lens. In the normal protocol, we have to treat both of eye. However, in a more customized management, we can choose stepwise correction. In our case, we start from the dominant eye. So we successfully superimposed the Presbyond LBV correction onto the phakic eye with monofocal lens. So the question for you, so what currently you can offer the surgical option to the patient pseudophakia with a monofocal lens? Is it LASIK or ICL or cornea inlay or IOL exchange? So of course, the EDOF lens such as the VVT or LARA can be a very practical solution. However, we should have a cornea-based procedure such as LBV in our toolbox, so that if we come into the case, the lens cannot be moved. To summary, using the extended DOF and mini monovision can deliver good visual quality, no matter in the phakic or pseudophakic eye. Both cornea-based and lens-based presbyopia correction are practical. Careful patient selection and personal visual demand are key to the success. Surgical intervention options are further burdened in the post-cataract surgery patient by Presbyond LBV. Thank you.
Thank you. Definitely thought-provoking. A lot of discussion there. But in the interest of time, we have 10 minutes past 7. So I don't want to hold you before your gala dinner. Again, thank you, Ramya, for actually co-chair with you. Thank you, everybody and speakers, for actually, deliver talk in time. Thank you so much, everybody. See you tomorrow. Thank you.